Arjit, are you there?
Yeah.
Hi all. We'll just give it a couple of minutes, waiting for people to gather, and then we'll start our webinar.
So we will have full time zones, morning, afternoon, evening.
Yeah, looks like it. All right. I think we should start. Do you see my screen, Sarah? Okay, perfect. Well, good morning, good evening, good afternoon, everyone. My name's Arjit. I'm a physicist at Houston Methodist Hospital, and I'll be co-moderating the session today with my friend Sarah Ashmed. I'll let her introduce herself. Sarah? Oh, yeah.
Oh, yeah. Good morning, everyone. Thank you for joining us today for this webinar. My name is Sarah Ashmek. I'm a Radiation Oncology Physicist at UPMC in Pittsburgh, Pennsylvania. I look forward to the talk, and thank you very much, Arjit.
All right. It is definitely an honor today for me to introduce our speaker, Dr. Ramiro Pino, who happens to also be my boss. He'll be talking on quality assurance for imaging in radiotherapy, a really important topic. We will have a Q&A session towards at the end of the talk once Dr. Pino is done. If you see there's a chat option and also a Q&A option, please by all means utilize these two options, and Sarah and I will make sure we note all your questions, and if the time doesn't permit, we will make sure that your questions are addressed, and we will send out an email once Dr. Pino gets to answering all the questions. For anyone or everyone over here who needs some sort of a attendance certificate, you will be sent a few multiple choice questions that once answered, then you will receive the certificate of attendance from Medical Physics will benefit. The webinar will be recorded and posted online at our YouTube channel. If you haven't yet visited, please like, share, and subscribe. So Dr. Ramiro Pino, he is the Chief Physicist and the Director of the Medical Physics Residency Program at the Houston Methodist Hospital in Houston, Texas. He is also the Associate Professor of Medical Physics at the Academic Institute, Houston Methodist Hospital, and the Weill Cornell Medical College, New York. He has contributions in radiation dose calculations and has also authored 2 patents. His clinical and research experience in areas of therapeutic medical physics, such as cranial and extracranial stereotactic radiosurgery, HDR, LDR brachytherapy, and commissioning of radiation treatment machines and treatment planning systems. As mentioned, please write your questions in chat, and we will be asking Dr. Pino the questions that you may have at the end of the talk. And again, thank you to Dr. Pino, AAPM headquarters, the Medical Physics World Benefit Board. I do see our new president here, although she is 2 hours behind. So thank you so much for joining, Afua. And of course, none of this is possible without all the attendees from all over the world. So without further ado, I'll stop sharing my screen. Dr. Pino, you can go ahead.
All right. I'm going to start presentation. Good morning, good afternoon, good evening, everybody. It's truly a pleasure to be here. Thank you, Arjit, for the invitation. My name is Ramiro Pino. As Arjit mentioned, I work at Houston Methodist in Houston, Texas. And today I will talk a little bit about quality assurance for imaging in radiotherapy and why it's important. This is us. This is Houston Methodist. We are based in Houston Medical Center and 7 other hospitals around the city. We have a bunch of machines, a bunch of simulators, brachytherapy afterloaders, a bunch of special procedure programs. But more importantly, we are a very large physics group. We all work together to provide our patients the best care we can. Disclosures, conflict of interest, I have nothing to declare. I'm employed by Houston Methodist, as I said before. I will mention several brand names, but it doesn't imply any endorsement of any kind. I'm gonna give a quick overview on quality assurance about CT simulators, MV image guidance, and KV image guidance for treatment. I'm gonna start with the sources of uncertainty. I'm gonna try to link them to simulation and to imaging during treatment. Target determination, GTV and CTV seems to be the largest source of uncertainty in radiation therapy. And this is linked to simulation, obviously. So when the doctors draw targets and when we draw normal structures based on a CT scan, quality assurance and the quality of the acquisition is very important. Machine operation, this particular case is related to the operation of the imager for treatment. Termination of radiation dose. If the imaging is not good enough, obviously the calculation will not be accurate. Patient-specific data for treatment planning. Again, related simulation, radiation dose calculations, as I mentioned before, also related. Transfer of data and daily variations in treatment, that's also very critical, which is related also to the quality and quality assurance of the image system that you have in the machine if you do image guidance. So clearly they're all related. These are the main sources. These are not all the sources, but these are the main sources of uncertainty in radiation therapy. Quality assurance, as defined, is all those planned and systematic actions necessary to provide adequate confidence that a product or process will satisfy given quality requirements. And that applies directly to radiation therapy. So we try to identify and minimize the sources of uncertainty and errors, trying to achieve the best possible safe treatment for our patients. That's the purpose, the definition and purpose of quality assurance. This is an overview of the main documents that we typically use for guidance in terms of the developing and performing quality assurance for Linux system QA like TG142. In terms of MV, KV, and CT-based imaging, there are several of them. And in terms of SIM QA and imaging those, TG66 and 75, and I show here the two most important ones, in my opinion, which is TG66 and TG142. So imaging therapy divided mainly in two groups. For treatment planning, typically we use CT. Some systems use MRI, Gamma Knife, for instance, or MR Linux. and ultrasound, particularly brachytherapy. But we also use auxiliary imaging, namely diagnostic imaging coming from other CTs, diagnostic CTs, diagnostic MRI, PET, and SPECT, and others. This is an overview, we all know this, of the radiotherapy process, and the purpose of this slide is just highlight what is the location of simulation in the whole process. So basically, after the patient is consulted by the doctor, typically they go for simulation. More often than not, they have diagnostic imaging, and then they go to treatment planning, treatment delivery, and then follow up. So the fact that simulation is at the very beginning is an indicator that any errors that are introduced during the simulation process would propagate throughout the whole process and will end up during delivery of the patient. Those are essentially, they become systematic errors that propagate through the whole process. This is a picture of our simulator, one of our simulators here at Houston Methodist, just to highlight the different components at high level. So you can see the CT bore, internal lasers, external lasers, the flat table for patients, the control room, and some other accessories that are of use during simulations, such as the breathing monitor or the contrast injector or a thermoplastic mask oven to prepare immobilization devices. So during the simulation, the patient is scanned, and typically we also obviously create immobilization and determine the patient positioning, depending on what procedure we're going to be performing. And typically, the CT scanner is in many aspects very similar to a diagnostic one, except that we use a flat table to be consistent with our treatment tables, which are also flat. We usually use a very large bore because we have immobilization devices that need to go through. And typically, we have immobilization and localization requirements. Treatment planning is performed on the treatment planning system, and the positioning of the patient at the machine, more often than not, is performed under image guidance. And typically, we create a list of requirements or pointers to the therapist to deliver treatment while the patient is on the table. For the simulation, we align the patient treatment position, we prepare immobilization, we mark the patient, we acquire images, and sometimes we drop isocenter, we mark the isocenter, and the patient positioning instructions are recorded. For quality assurance for CT simulation, we typically use Task Group 66 document, which is not fresh anymore. It's about 20 years document, but it's still very useful, and gives a lot of good guidance on how to perform quality assurance on those systems. And the QA recommended start with obviously radiation safety. Once you get your CT scanner or simulator in the room, shielding study needs to be performed. Make sure that shielding is adequate to protect the public and the employees. There is a baseline radiation dosimetry needs to be performed, and we need to do laser QA, table QA. We need to check for gantry tilt, scan localization, CT dosimetry in general, radiation profile, sensitivity profile, and generator tests. An imaging test, we typically look for Hounsfield number accuracy, image noise, spatial integrity, field uniformity, the conversion table from Hounsfield units to electron density, spatial resolution, and contrast resolution. So typically in the simulator, we have two sets of lasers. We have the one that are in the gantry, internal lasers, and typically we have external lasers as well. Obviously, all of them need to be QA. Typically, we have requirements in terms of positioning and motion. This is one of the phantoms. It's called the TG66 Phantom, which is because it's associated with the TG66 report, and basically has some accurate positioning and markings that you can use to test all the laser motions and often the couch motions as well. Another one that is popular out there is the Wilkes Phantom that also serves similar purposes. It's a little more compact. External lasers need to be precise in motion, linear, reproducible, and typically they are used to mark points on the patient, isocenters, and so on and so forth. The table, as I mentioned, needs to be flat. Often has specific positionings that are used to register mobilization devices, which are called index or index bars or index markings. And necessary criteria for this table for the simulator are they need to mimic the treatment table, need to be flat, level, orthogonal, similar sag to the one that we use for treatment. And the motion indicators and table position must be accurate and reproducible. Typically, we'll want the table to be leveled in relation to gravity. That's easy to measure. Typically, use a level. We need to verify the motion of the table, and typically in vertical and longitudinal motions. Tail, typically, many scanners have the ability to tilt, not typically used in simulation, and even some treatment planning systems do not accept non-zero tilt. So it's important the accuracy of the tilt is checked for the scanner. The scan and survey needs to be checked, and we need to verify that actually what we're planning to scan is actually the correct volume. We have profiles in the beam that comes out of the X-ray tube. We call one of the collimation system is the pre-patient collimation system, which is the one before the collimates the beam coming out of the X-ray tube before it hits the patient. And this is something that is important to keep under control within the specs of the vendor, because an excessive wide radiation profile will result in a necessary dose to the patient without acquiring extra data. And an excessively narrow profile will lead to increased quantum noise, which is also undesirable. And we also have the post-patient collimation, which is basically collimation before the detector array. And that will define the image itself. And again, we need to keep that profile, sensitive profile, within specs because of the implications of it. An excessively narrow will lead again to quantum noise, and excessively wide will lead to a loss of resolution. And typically we use an inclined metal wedge for this one. For the profile, pre-collimation profile, we typically use a film. We have also the patient dose, which typically is measured through CTDI, which is an integrated dose along the Z-axis. In practice, the 100 millimeters, what is measured. CTDI is typically 2 times higher at the surface than it is at the center. And we have other parameters that are indicators of dose to the patient delivered, typically the dose length product, which are defined here. Again, CTDI is often defined using those integrations over a scan, and they are a little different from axial and for helical scans. Typically, 2 phantoms are used. A head one, which has a smaller diameter, 16 centimeters, and a body one, which is about 32 centimeters. And here we have the formula for CTDI 100. Obviously, we need to correct for temperature and pressure. We have a conversion factor reading and the calibration factor of the detector of the pencil ion chamber. The generator test will test the performance of the X-ray tube itself, the peak kilovoltage, the half value layer, which is related to the beam quality, the linearity of the mass of the milliamp per second, its reproducibility, the timer accuracy, and the focal point size. Typically, we would like to use a non-invasive way, and there are several products out in the market that could be used for that purpose. The frequencies and tolerances are important. Radiation safety typically it's done initially unless you have a significant change in the shielding of the room or a massive change in the X-ray tube. CTDI should be measured annually and after any new component. The laser alignment is recommended to be done daily, monthly, and after any laser adjustments. And I'm listing the tolerances here at the right. The table orientation is important. Be checked monthly, as well as the vertical and longitudinal motion. Indexing and positioning is checked annually, as well as tilt, scan location, the width of the radiation profile, and the width of the sensitive profile as well. And the generator test should be done initially and after every component replacement, but we typically do it also annually just to make sure that the tube is performing as expected. So again, the TG60 recommended imaging tests are related to Hounsfield units, image noise, integrity, uniformity, resolution. Typically, for a scanner, we use a phantom that contains a number of markers that could be used for that purpose. In this particular case, I'm showing the CAT phantom, which has known Hounsfield unit plugs that could be used to check the precision of the Hounsfield units, as well as spatial resolution, contrast resolution, and uniformity, depending on what plane you are scanning in the phantom itself. Again, Hounsfield accuracy, Hounsfield unit accuracy typically is measured very often. Daily, we typically check for water. Monthly, we check for more, and annually, we check even more plugs. Image noise is checked typically daily. The Hounsfield unit accuracy will tell you how the kilovoltage is functioning if you don't have a major change in it. The image noise will tell you more about the mass. Significant change may indicate an issue with the tube itself. In-plane spatial integrity, it's important that you don't have distortions in the image acquired. Field uniformity typically acquired monthly and annually, and the conversion table should be checked annually and after every calibration, as well as the spatial resolution and contrast resolution. Although, since you do multiple Hounsfield units plugs checks monthly, it's pretty straightforward to check spatial resolution and contrast resolution monthly as well. So now we're going to image guidance. I'm going to mention here that you could use a portal imager to do image guidance. And in this case, we're using the beam to actually image the patient. And that's what we call the MV or portal images. I'm showing here two commonly used machines, a Varian and a Electro machine. And typically, we do a comparison between the image acquired and the digitally reconstructed radiograph from the CT scan that we acquired for simulation. And based on that comparison, we can determine shifts, and we can apply them. We can also do 3D MV imaging. Is not as popular, but there are two systems out there in the market that are fairly common. One of them is tomotherapy, which does helical acquisition of an MVCT, and the Halcyon, which does both KV and MV CDCTs. And these are some samples of images. For instance, for this particular machine, which is a variant true beam, you have here a mounted onboard imager that has a tube and an X-ray detector, a panel, and you can acquire either planar images or cone beam CT. And this is an example of a comparison between a conventional CT and a cone beam CT. And generally, cone beam CT tends to have lower image quality, although there have been improvements in that regard, significant improvements lately. One component I want to mention here very briefly is the fusion or co-registration, which is an important component because based on this co-registration is how we determine the shifts and how we apply them. Fusion or co-registration helps delineate targets and track targets for delivery, but it also introduces uncertainty. So it's important to know that co-registration is also a source of uncertainty. For treatment delivery image guidance, the main document we use is TG142, which is quality assurance for medical accelerators. It's already like almost 15 years old, but it's very useful as well with lots of details on what to do and often how to do it. So this is a list of the commonly available CT-based IGRT systems. The Elekta XBI, the Variant Onboard Imager, Siemens Artist, Tomotherapy, and Siemens Primatom, which I haven't seen one in a long time. Basically, because you have a mounted imager, the detectors, whether it's the MV detector or the KV detector, and even the KV source, they will flex, they will change position depending on the gantry orientation, and that needs to be corrected. It's called panel or detector or source flexing. These are two examples of phantoms that can be used to check geometric accuracy of isocenters and known shifts, and this could be used both for KV or MV image guidance, both planar or 3D imaging. The panel needs to be calibrated periodically depending on manufacturer specs, and typically you have a dark field, which is basically the background noise, and you have a flood field, which basically measures the sensitivity of your detectors, and then you apply corrections. In terms of routine QA for kilovoltage and megavoltage imaging, collision interlocks are important. Typically, these are C-arm systems, except for tomotherapy and the Halcyon, which are ring-based. So collision interlocks are important. Position and reposition is one of the most important tests that you can perform on a daily basis, as well as imaging and treatment coordinate agreements. Remember, you're now tracking or guiding the positioning of your patient based on your imaging system, but at the end, you're delivering from a different source, often from a different source, and it's important to make sure that those two isocenters agree. Scaling is obviously very important: spatial resolution, contrast, uniformity and noise, image dose, and beam quality and energy. For 3D imaging, again, very similar, because collision interlocks, position repositioning, isocenter agreement, distortion, and so on and so forth. And many of these tests are very similar to the ones I mentioned for the CT simulation. I believe that positioning is more important than image quality in IGRT. Of course, if you cannot see the target, it's very difficult to make any guidance. But typically, we use relatively high dose gradients for treatment. So any small errors in positioning will translate in significant changes in the dosimetry of your target, especially in the era when we use very tight margins to treat patients. So typically, we test that daily, very important. We place a phantom, we take images, we apply shifts, and we verify the shifts. These are two examples of simple phantoms that could be used for that purpose. Isocenter coincidence could be also done using those cubes, but there are some dedicated phantoms that could be used to correlate both isocenters. And in this particular one that I'm showing on the right, will allow also for checking for scaling and dimensions. In the case of a CT scanner, you can use markers, in this particular case for a CAT fan, that are inside the phantom itself, and verify that what you're measuring in the image is actually what you are expecting to measure. This is, sorry. These phantoms are used for 2D contrast and resolution, and I'm showing here 3 examples, some for KV, some for MV, and you can measure contrast resolution and spatial resolution after taking a single image. So uniformity at noise, also measurable, and we need to keep track of it. In 3D, it's similar to 2Ds, except that we track certain areas for uniformity and also for Hounslow unit accuracy using the plugs that are provided for the phantom, as well as spatial resolution, which often, or more often than not, depends on the imaging protocol. Head has high resolution, for instance, and pelvis in the protocols typically. At the same time, contrast and noise also are highly depending on the protocol. As I mentioned, contrast resolution, they look different in a CT than they look in a CBCT. Typical CBCT has more scatter and more distortions. And as I mentioned, there have been significant improvements in the last year or so. MV IGRT imaging dose. Most of the time we use the beam, the treatment beam for doing that imaging. So if we have a calibrated beam, which we're supposed to have, then it's straightforward to calculate dose based on the treatment planning system or manual calculations. The exception is that some linear accelerators will come with a lower energy beam that could be calibrated as well, but it's sometimes dedicated only for imaging or dedicated only for imaging, not for treatment. The KV IGRT imaging dose, there are many meters out there, and as I mentioned, it's similar process using CTDI with the pencil camera chamber and this head and body phantoms. I'm mentioning here the TG142 tolerances for daily, typically one collision interlocks, positioning and repositioning, and imaging and treatment coordinate coincidence, both for planar and cone beam CT. And the tolerances depend on what type of treatment you are trying to perform, whether it's a 2D, 3D, or it's a SRS or FBRT. Monthly, they're more detailed. We include also scaling, spatial resolution, contrast, uniformity, and noise. For annual, we go beyond the monthly. We check the full range of the motion of the epid. We also measure beam quality and energy and imaging dose for KD and CBCT imaging. So this was shorter than I expected. I was talking really fast. In summary, the medical physicist is responsible for designing and maintaining a clinically relevant and accountable quality assurance program. Checklists are very important, and they should be based on recommendations from professional organizations, for instance, AAPM, as well as regulations. It's very important to meet regulations. It's important to maintain good communication between all members of the QA team and set clear action levels. More often than not, other members of the team, not the medical physicists, are the one performing those tests, especially daily. Ultimately, the medical physicist is responsible for it. So when anything is detected, open lines of communication are very important. Obviously, commissioning is very important. I didn't talk a lot about that. And end-to-end testing for any new technologies, including a CT simulator and onboard imaging. As I started the presentation, errors in simulation will propagate through the RT process. That means it's very important to maintain a high quality simulation quality assurance program, as well as image guidance. And personally, I recommend using TG68 and TG142 protocols for CT simulation and treatment imaging QA. And we have plenty of time for questions. I went over 61 slides in 35 minutes, which for me is a record. Thank you all.
Okay, great talk. Thank you, Dr. Pino. We have quite a few questions, and we have good attendance today. We have 100 actually. So popular presentation. Let's start with the first question. It had to do with lasers. So the question was, sorry, if there's an inconsistency between the external and internal lasers of the CT, which one do you rely on more, I guess? The question was exactly which method would you recommend? Like
So the whole idea is to keep them in line. So if you have an inconsistency, you need to resolve it. That would be my first recommendation. It depends also on what do you use your external lasers for. If your external lasers are typically used for marking, and also for checking for patient alignment. Typically, we want the patient to be straight and to be leveled, typically. And we use that for that purpose. So if the purpose of the external laser is secondary, then obviously you rely more on the internals. But if it's more critical, then if it's critical, mission critical, you need to fix your discrepancies.
Okay, thank you. Now the next question is about the Hansfield convergence electron density, the HUED. What's the purpose of the test?
Oh, okay. So the treatment planning system used density for heterogeneity corrections. And the CT scanners and lately also the onboard imagers simply acquire images that only generate Hounsfield units. So during the commissioning process, you need to establish a correlation or a table that will connect the Hounsfield units that are coming from your scanner or from your imaging system in general to the density. And that density table is the one that is used for those calculations. It's a very important process. And of course, we need to check periodically whether that table is still valid. And if there is a significant change because of tube wear and tear, then those tables need to be adjusted.
Okay. Next question I had to CAT-PAN. If you have any preference between CAT-PAN 501, 601, or 701, if you would recommend one
We
over the other?
typically use the 601, but you would have to look at specifically you want to measure it if it meets the requirements of your quality assurance program. So you want to look at your spatial resolution, integrity, Hounslow units, and so on and so forth.
Okay. The next question has to measure with the focal spot for CT. Do you ever measure that? And do you use a specific detector for it?
And I'll pass on that question. We typically outsource those details of the CT scanner and even the OBI to our colleagues in diagnostic imaging. So, sorry, pass on that one.
Same here, same here. Okay. And probably I think the next question might be similar. Why? Because it's asking about how often you measure aluminum equivalent in CT and also for LINAC.
So
Maybe not for tabletop.
that's probably half value layer, and we measure that annually. Typically, again, we can measure that, but typically delegate it to our colleagues in imaging physics.
Okay, okay. Now let's go to the next question here. What difference in position shift should we treat as an action limit?
Okay, that's actually not a hard one. It's tabulated in TU-142. So typically you want about 2 millimeters for anything that is 3D, IMRT. But if you go to high dose perfraction, then you should keep it at 1 millimeter.
Would you say if you can't tweak it to that tight, then you should incorporate that when planning or creating the PTV?
Can you repeat the question? I'm sorry, I missed it.
I'm saying if for whatever reason the machine cannot go to that tight, then they should keep it in mind when planning, right? When they're creating their PTV. Would you agree?
To a point. Again, margins are there to make sure that we're treating the target that we're supposed to be treating, but at the same time, expanding targets too much will have consequences. You will be treating a lot more normal tissue, potentially critical structures. So there is always a trade-off on how you manage things. But definitely, when your uncertainty is larger margins is an option.
Okay, thank you. The next question is, if someone wants to start BMAT transitioning from 3D conformal radiotherapy, what quality checks they should follow?
Okay, there is a long list of things that you need to do. I would recommend looking at Astro white paper on IGRT and VMAT IMRT. There are a lot of requirements in terms of technology. So you have to have the proper imaging system, the proper treatment planning system. You need to get people trained. You need to make sure that your machine is capable of delivery, that your image guidance is adequate. Again, go through the whole commissioning program, do end-to-end testing, do practice runs. So it's a whole process, and it includes from determining the right group of people, the right training, all the way to commissioning and end-to-end testing. It's a long process, and it goes beyond image quality, definitely.
Okay. The next question has to do with the variation of KVP on your CT. So the question is, which calibration or the calibration curve of which KVP do you use mostly for your TPS?
120 KVP, that's what we typically use.
Yep. Okay.
Simple. You can use others, but then you have to have different tables.
Yeah. Okay, I think covered most of the questions. There's a question that I did not understand. Go ahead, Arjit, please.
Yeah, there's one question that just got added. How can we improve QA using AI technology?
So There has been quite a bit of research in the last couple of years in using AI for QA. Most definitely, a well-trained AI should be able to detect trends and figure out what issues may be showing up. There is a lot of information that is generated in the machines themselves and using the QA devices. So yeah, you should streamline the whole QA process. Truly, we don't do a whole lot yet, but I think that's part of the future. There was a question about Linac for QA imaging. Personally, I have seen it used. I cannot vouch for it. We use other products, but I know of people who have been using it, and it's basically has a collection of Python-based tools that actually automate some of the QA, which I think is very useful. I would not recommend it directly because, as I said, I have never used it before, extensively at least. I would validate it first before using it in the clinic.
There's another question. We have Halcyon for IMRT using IGRT technique. So in your opinion, can we use CBCT image for treatment planning?
The straight answer is no. That's the straight answer. The qualified answer is that Varian actually offers a protocol Ethos. But Ethos actually does not use directly CBCT unless you have hypersight. Hypersight is a different story. Hypersight is almost the same quality as a CT, regular fan beam CT. So you can build your Hounsfield unit density tables and you can use them directly. In the case of the standard 43 by 43 panel, Varian uses a synthetic CT because often you have artifacts. Your Hounsfield unit density conversion table is not accurate enough. And more often than not, your field of view is cut off. So they use synthetic CTs, often based on AI, to generate the CTs that they can use for treatment planning for adaptive therapy. But directly, I don't think you can try, but it's off label, I would say. Let me put it that way.
Okay. Someone just asked if someone doesn't have EPID total dosimetry license, what should they use to check MLC picket fence?
Of course, you can use film as well if you don't have the EPID. So picket fence is a good test for MLC. There are other tests, but truly, the EPID simplifies the quality assurance of MLC tremendously.
Okay, there's a question, I think it was repeated, I probably missed it first time. It says, any difference in target delineation and dose calculation on the CT reconstructed versus reformatted images? I don't think I understand the question.
Can you? I'm trying to find the question.
It's before I wrote Hypersight.
Okay.
Before it, by Ramesh Prasad. It says any difference in target delineation and dose calculation on the CT reconstructed versus reformatted images.
I'm assuming between planning CT and cone beam CT. I don't know.
Any difference in target delineation, dose calculations, CT reconstructed versus reformatted images? Ooh, I'm not sure I understand that question. Typically, when For ethos, they create a synthetic CT based on the CBCT, and they also propagate the contours that were originally drawn on the simulation CT. But once you propagate or you use AI to determine contours, they need to be reviewed and approved by typically physics and physician. I don't know if that answers the question.
I don't know. He followed up saying this is when scanner produce exact slice thickness radio format. I think, Ramesh, if you want to speak up, it's okay for you to turn on your mic so we can understand your point. Ramesh?
The process of reconstruction of a CBCT is a little different from a helical fan beam CT. So I don't know what you mean by exact slice thickness.
I don't understand either. So going back to Hamid about the picket fence, he's asking if there's an open source tool that can be used for film analysis.
I think the Pylena can be used for film as well. I cannot guarantee you that, but I believe that's the case. You need to have a film, either chromic or radiochromic or silver based. For silver based, you probably need to have a processor. Lately, not a lot of people have processors.
I've never tried it. Can you use ImageJ to analyze picket fence? I never used it for that purpose.
No, I have never used it either. You would have to, I don't know, draw lines and determine which leaves may be off. I don't know if there is any automated. Maybe you can write a script, but
there you go.
I have never tried.
Yeah. Okay, so I guess someone used ImageJ, Joseph. Okay. I guess if I have a question, if people
Yes.
don't have more questions, do you incorporate the CBCT dose or whether it's MV or KB in your planning, or not
No.
really?
Not really.
I don't think anyone is doing that yet, right?
Now we try to maintain the number of CBCTs to a reasonable number. We don't like the therapists to do more than 2. If they have trouble, we always ask them to get physics to try to figure out what's going on. But particularly pelvis, CBCTs give a lot of dose to the patient, so that's something that needs to be taken into account.
And that's 2 per fraction, right?
Yes, correct.
Okay. Good. Oh, there is one more question regarding Versa HD Linac. We observed too much noisy imaging from CBCT. Even though they pass all the contrast tests, how to proceed to solve this problem?
Okay. I'm going to be shooting from the hip here because I don't have Electa machines. But if you change your window and leveling, I'm pretty sure the noise problem will go away. It's just a trick. But if it's truly a noise problem, then you may need to take it to your vendor and make sure that it meets specs. Hounslow units for CBCT are almost never equivalent to diagnostic CT Hounslow units. Hypersight has improved a lot on it. They are much closer. I don't think they are quite there, but they are much, much closer. But in general, the general rule of thumb is that they are not. Okay, Hamid has tried Pylinac. Yes, you may want to validate the product so you can use it confidently in the clinic and make decisions based on the results.
Yeah.
All right, looks like we are. Oh, yeah, I think, yeah. Further
Okay.
questions we can definitely send to Medical Physics World Benefit, and we will pass them on to Dr. Pino. But just in the interest of time and respect for everyone, I think this will be a good point to end our session. Please watch out for an email from MPWB. We'll send out the questions. So if you do need a certificate of attendance, please do answer those questions. And also, as mentioned earlier, please do follow us on LinkedIn, X, or YouTube, and you will find our recording for this talk over there also.
All right.
Thank you.
Again, thank you very much for an invitation.
Thank you.
And if there are any questions I can answer, I'll be happy to answer them offline.
Thanks,
Awesome.
Arjit and Sarah.
Thank you.
Bye.
All right.
Awesome. Thank you. Bye.
Thanks, everyone. Great talk.